If you sprain your ankle, it swells up, right? It turns
Mhm.
this vibrant, angry
Oh, yeah.
purple.
It's a very public, highly visible display of pain.
Exactly. Like, the diagnosis is just obvious to anyone who's looking at you. And the treatment plan is incredibly straightforward. You rest it, you ice it, you elevate it.
Right.
But, what happens when the pain is entirely hidden? What if the pain is so deeply embedded in a part of the body that society, well, they barely even want to talk about it?
It becomes this incredibly isolating experience. I mean, that isolation, the inability to just point to a cast on your arm and say to your friends or your partner, hey, this is the thing that hurts, it amplifies the suffering exponentially
Yeah, that makes sense.
because we're conditioned to, like things that are visible and easily categorized.
Yeah.
When a medical condition doesn't fit neatly into a box, the diagnostic waters just get super murky.
Hmm.
And patients often end up spending years suffering in total silence.
And that silent suffering is exactly what we're focusing on today for you in this deep dive. We are looking at a condition that affects up to 16% of women.
Which is nearly 1 in 5.
Right, 1 in 5. So if you're sitting at a table with a group of friends, the statistics suggest someone there is likely dealing with this. The condition is called provoked vestibulodynia, or PVD.
Yeah.
And to uncover the clinical efficacy of a really highly specific, very new treatment for it, we are pulling from a massive stack of research for you today. I mean, we've got clinical trial protocols, funding data from the Canadian Institutes of Health
Oh,
Research.
thanks, Terry, yeah.
Exactly. Plus, guidelines from the European Association of Urology and a bunch of clinical white papers from pelvic health specialists.
And our focus across all those documents is really trying to answer a single crucial question. Can we treat this pervasive, debilitating condition by inserting very thin, totally unmedicated needles directly into the muscles of the pelvic floor?
Which just sounds intense.
It does. It sounds intense, and to a lot of people, it sounds completely counterintuitive. But the data we're going to walk you through today reveals this fascinating intersection of chronic pain, muscle tension, and how the nervous system can essentially just misfire.
So let's start by defining what the patient is actually experiencing here. Because the medical term you'll see scattered throughout all these clinical papers is refractory superficial dyspareunia.
Right, which is quite a mouthful.
It really is. But for a patient, what that actually translates to is sharp, often burning, and completely debilitating pain at the vaginal entrance.
Yeah, and this happens upon any kind of pressure or attempted penetration.
Right.
It's so important to understand the severity of that pain. I mean, this isn't just, mild discomfort. It is a severe pain response triggered by things that absolutely should not be painful.
Like tampon use or wearing tight clothing.
Exactly. Or sexual intimacy. And because of the intimate nature of the pain, historically, women they were often dismissed by the medical community.
Oh, totally. Like it's all in your head.
Right. They were told it was psychological or a result of anxiety or simply something they just had to endure. But the modern clinical understanding has shifted entirely. The pain is not in the mind at all. It is rooted in very real structural and functional muscular abnormalities.
Okay, so reading through the papers, I kept seeing this phrase, viscerosomatic convergence, when they described the root cause of this pain. What exactly is converging there?
So it really comes down to how our internal wiring is organized. Your internal organs, that's the visceral system, and your muscles, the somatic system, they actually share neural inputs that travel to the exact same regions of your spinal cord.
Oh, interesting.
Yeah. And because those nerve pathways overlap, the brain can get really easily confused about where a distress signal is actually coming from.
Right.
So a dysfunction or irritation in an organ can manifest physically as intense muscle pain. And conversely, severe muscle tension can mimic organ dysfunction.
Okay, so it's essentially like a faulty home security system.
Yes, exactly.
Like, you install this state-of-the-art alarm system to protect your house, but the sensors are calibrated completely wrong. So a harmless breeze blows a curtain in the living room, and suddenly the alarm triggers a full-blown police response.
Perfect analogy.
Sirens are blaring, lights are flashing. So the pelvic floor in someone with PVD is that alarm system, right? It's clenching in a perpetual state of high alert against a threat that isn't actually there.
The alarm is blaring and the doors are aggressively locked. And in the pelvic floor, that constant state of lockdown is called hypertonicity.
Hypertonicity.
Yeah, it's extreme, unrelenting muscle tightness. And the thing is, when a muscle stays in that contracted, hypervigilant state for long periods without ever fully relaxing, it becomes hypoxic.
Meaning it's starved of oxygen?
Literally stars of oxygen, yeah.
So what physically happens inside the muscle tissue when it can't get oxygen for that long?
Well, the tissue essentially just goes into survival mode. The hypoxic state forces the muscle fibers to release this cascade of inflammatory biochemicals.
Oh, wow.
Yeah, think of it as a toxic acidic soup that just begins to pool inside the muscle tissue.
Gross.
It is. And these inflammatory chemicals, they constantly bathe the surrounding nerves. So over time, that constant chemical irritation causes the nervous system to undergo something called central sensitization.
Central sensitization.
Right. The nervous system physically alters itself and actually lowers its pain threshold.
Meaning everyday, completely harmless sensations, like just the friction of a pair of jeans, are suddenly registered by the brain as severe tissue-damaging pain.
Exactly. The wiring has been totally hijacked by that inflammatory soup.
So the brain is receiving a signal that the tissue is being destroyed, even though it isn't at all.
Right. The body has created this brutal feedback loop. You have muscle tension causing chemical inflammation, which causes nerve sensitization, which then causes more muscle tension.
The total vicious cycle.
And within those tight muscles, you develop myofascial trigger points. These are highly irritable, localized knots within the taut bands of the muscle fiber.
Okay, wait, because this is where I have to push back a little.
Sure.
Thin needles inserted into the skin to treat those knots. I mean, that just sounds like acupuncture with a rebrand.
I hear that all the time.
Right. If you're a patient looking for relief, why does it really matter what we call it?
It's a very common question, but the distinction is actually critical for understanding why this specific treatment works. So, traditional acupuncture is rooted in Eastern medicine.
Right, with the energy line.
Exactly.
Yeah.
The goal is to balance the flow of energy, or qi, along predefined meridians throughout the body. Dry needling, however, completely ignores those energy meridians.
Okay.
It is strictly based on Western neuroanatomy and neuromusculoskeletal science.
So the practitioner isn't like looking at an energy chart on the wall. They are looking for a physical abnormality in the actual tissue.
They are actively palpating or feeling the pelvic floor muscles. And these are deep, often really hard to access muscles like the obturator internus or the pubococcygeus. They're searching for the exact hypertonic band and the specific myofascial trigger point that is causing the dysfunction. And then the needle is inserted directly into that physical knot.
And these are tiny needles. I mean, looking at the protocols, they're monofilament needles, usually between 25 and 70 millimeters long, depending on, the depth of the muscle.
Yeah, super thin.
And it's called dry needling because there is absolutely no medication involved, like no cortisone, no Botox, no local anesthetics.
Nothing, just the needle itself.
Which brings up the million-dollar question, right? How does a tiny, dry metal needle physically force a muscle fiber to release a knot that has been locked tight for months or even years?
Well, it acts as a profound mechanical and neurological disruptor.
Okay, how so?
When the tip of the needle hits that precise trigger point, it elicits what's called a localized twitch response.
A twitch?
Yeah, it's an involuntary spinal cord reflex. The needle mechanically stimulates the motor end plate of the muscle fiber, which forces the contracted band to rapidly twitch and then finally just let go.
Wow. Like popping a balloon of tension.
Exactly. It is a sudden physical release. And what happens chemically at the tip of the needle right after that twitch is equally important.
Because of the blood flow.
Right. By breaking that localized contracture, you instantly restore normal blood flow to the area.
Yeah.
Fresh, oxygenated blood just rushes in, and it flushes out all those inflammatory biochemicals.
That toxic soup we talked about earlier.
You got it. You are literally removing the chemical irritant that was bathing the nerves and keeping the pain threshold lowered.
So you are simultaneously fixing the hypoxia and stopping the central sensitization.
Yes. And beyond the local tissue, the needle also acts directly on the autonomic nervous system.
Oh, really?
Yeah, the intervention downregulates the sympathetic nervous system, which is your fight or flight response, and it upregulates the parasympathetic nervous system, the rest and digest mode.
Oh, so it's like flipping the switch on the main control panel of our faulty home security system.
Exactly.
It tells the central nervous system, hey, you can stand down now. The localized threat is gone. The curtain is just a curtain.
And the clinical results of forcing that reset can be just staggering. I mean, there's a fascinating case study by Johan and colleagues. This is from 2012 in the sources you mentioned.
Right, I remember that one.
They treated a 50-year-old woman who had a 20-year history of vulvodynia.
20 years! That is 2 decades of persistent life-altering pain.
It's unimaginable. But after just her first session of dry needling, targeting those specific pelvic floor trigger points, she reported a 50% improvement in her symptoms.
Wow.
And after her second session, she experienced 100% improvement.
That's crazy.
Yeah, and 9 months later, at her follow-up, she was still completely symptom-free.
Okay, I mean, a single case study of a 20-year pain just disappearing after 2 sessions is an incredible story. But as a skeptic, I can't help but wonder if that's a massive placebo effect.
Which is a very fair point.
Because think about it. A patient suffering for 20 years finally feels validated. She receives this intense, highly focused physical intervention. Of course, she might feel better temporarily.
Right.
Has anyone actually put this to the test with a rigorous control group?
Well, the medical community shared that exact same skepticism. Historically, the European Association of Urology guidelines stated that the evidence for dry needling in pelvic pain was, quote, weak.
Ouch.
But that wasn't a judgment on the treatment itself. It was an indictment of the research.
Because the studies were flawed.
Exactly. The existing studies were small-scale, they were poorly designed, and they lacked proper control groups to rule out the placebo effect you just brought up. To build a new standard of care, you really need robust, empirical data.
Which brings us to the randomized controlled trial led by Dr. Melanie Morin at the Universidad of Sherbrooke.
Yes.
And I think it's really worth noting here that this was funded by the Canadian Institutes of Health Research. That adds significant weight and institutional backing to the investigation.
Oh, absolutely. So Dr. Morin designed a feasibility trial to test this very specifically on 46 women diagnosed with PVD.
Okay.
And they were randomized into 2 groups. One group received 6 weekly sessions of real dry needling into their pelvic floor trigger points.
And the other group?
The other group received sham dry needling. It's a sham-controlled trial. So the second group went through the exact same motions, but the needles didn't actually penetrate the trigger points.
Oh, clever. So that controls for the psychological impact of simply receiving the care.
Exactly.
So let's talk about the results, because the data here paints a very, very clear picture of what happened.
It really does. The real dry needling group saw a clinically significant decrease in pain intensity compared to the sham group.
By how much?
The primary outcome measure showed a mean difference of 2.4 points on a 10-point pain scale, and the p-value was less than 0.001.
Wow, so that is highly statistically significant.
Highly. And in practical terms, a 2.4-point drop is huge. That is often the threshold between a pain level that prevents sexual intercourse entirely and a pain level that allows a patient to actually reclaim that part of their life.
So the pain during intercourse markedly decreased.
Yes.
But if you look at the compliance data in Morin's trial, honestly, that is what stands out the most to me.
The attendance rates.
Yeah.
Yeah.
Because a feasibility study isn't just about whether the treatment technically works in a vacuum. It's about whether patients will actually tolerate it in the real world, before they fund a massive multi-center trial.
Will people actually show up for this?
Exactly. And the real dry needling group attended 99% of their planned sessions, and there was a 0% dropout rate.
That's unheard of.
0 dropouts for a treatment that involves inserting multiple needles into one of the most sensitive private areas of the human body.
Yeah.
To me, that just suggests the relief they felt was deeply tangible. Like, it was absolutely worth the physical and emotional vulnerability of the entire process.
That compliance data is so vital. Because if we look at the sham group, they had a 91% attendance rate and 2 dropouts.
Okay, so still a good retention rate for the sham group.
Right. Still good, but the real treatment group was virtually perfect. It proves that a larger double-blind RCT, which, by the way, is currently in the works, is highly feasible.
That's great.
It provides the gold standard empirical evidence that medical guidelines demand in order to move a therapy from the fringe to a validated first-line medical treatment for dyspareunia.
Okay, but let's look at the side effects for a second, because we definitely need a reality check on the actual patient experience here.
Sure.
It's not just a magic wand. In Dr. Morin's trial, 96% of the participants in the real dry needling group experienced muscle aches.
Yeah.
Compare that to only 52% in the sham group. And furthermore, 35% of the real dry needling group experienced autonomic reactions during or after the treatment.
Right, the autonomic responses.
We are talking about sudden sweating, temporary dizziness, or feeling flushed. If you're a patient reading that, aren't you just like trading one pain for another?
I can see why it looks that way on paper.
Right. Like, why subject yourself to needles and dizzy spells when you could just undergo standard physical therapy massage?
Well, you have to view those side effects through the lens of physiology rather than just, discomfort.
Okay, explain that.
The muscle aches and the autonomic reactions are actually physiological evidence that the intervention is working.
Oh, really?
Yeah. The sweating and the dizziness occur because that localized twitch response causes a sudden discharge of the sympathetic nervous system as it resets.
Oh,
It's a localized, intense shock to the tissue that essentially forces it out of its dysfunctional pattern.
so it's literally the physical manifestation of the system rebooting.
Exactly.
Almost like the pain of progress, like the intense soreness you feel after physically breaking down a muscle during a heavy workout, just so it can rebuild stronger.
That's a great way to think about it. It is a profound neurological reset. And when you compare it to standard manual therapy, things like myofascial release or internal pelvic floor massage, the time frame is drastically different.
How so?
Well, standard physical therapy for PVD often requires 10 to 12 sessions, or sometimes up to 24 sessions over 6 months to achieve significant results.
Wow. That is a massive time commitment, not to mention the financial burden of paying for 24 specialized therapy sessions.
Exactly. But dry needling can radically accelerate that timeline. When it's used in synergy with manual therapy, it creates a highly potent combination.
Because it goes deeper.
Right. The needle can penetrate to depths and target specific aspects of the obturator internus muscle that a physical therapist's finger simply cannot reach or manipulate as effectively.
Ah, okay. So the needle breaks the chemical and physical deadlock deep in the tissue.
Yes.
And then the traditional manual therapy is used to rebuild the healthy function and sort of retrain the muscle now that it's actually capable of relaxing.
Precisely. By breaking that initial deadlock so quickly, dry needling drastically reduces the total number of physical therapy sessions needed overall. It offers a much faster pathway to long-term liberation from chronic pain.
Okay, so if the clinical data is this strong, and the synergy with physical therapy makes the whole process so much faster and more efficient, why isn't every pelvic floor physical therapist doing this?
It's a huge issue, and the access barrier is incredibly steep. An international survey of physical therapists who treat pelvic pain revealed a massive disconnect in the field.
What kind of disconnect?
Well, while 30% of them believe dry needling is an effective intervention based on the emerging literature, less than 17% actually use it frequently in their practice.
Wait, almost double the number of practitioners believe in its efficacy compared to those who are actually permitted or equipped to do it.
Exactly.
Why is the utilization so low?
It hints at two major hurdles. First, this intervention requires highly specialized advanced training.
Right.
Navigating the complex, delicate neuroanatomy of the pelvic floor with a needle is not a skill a practitioner just picks up in a weekend seminar.
I would hope not.
Right. And second, and perhaps more restrictively, there are strict jurisdictional practice laws.
Oh, like state-by-state regulations.
Yes. Depending on the state or country where a patient lives, physical therapists may not be legally permitted to pierce the skin under their scope of practice.
Wow.
So this leaves a highly effective, scientifically validated tool completely inaccessible to the patients who need it most, simply because of regional regulatory red tape.
That is incredibly frustrating. But, for the millions of women and men, too, who are suffering in silence from pelvic floor dysfunction and provoked vestibulodynia, the research we've explored today offers a very tangible sense of hope.
It really does.
I mean, dry needling isn't just a holistic trend making the rounds on social media. It is a precise neuroanatomical intervention backed by rigorous clinical trials like the work being done by Dr. Marin. It's a targeted way to flush out inflammatory chemicals, physically release locked muscle fibers, and hit the reset button on a nervous system that has been trapped in a state of high alert for far too long.
And this precise mechanism actually forces us to reconsider how we approach chronic pain globally, which leaves us with a fascinating, perhaps provocative thought.
Okay, let's hear it.
We've learned today that the pelvic floor is a critical intersection. It's a place where localized, hidden muscle tension can literally rewire the central nervous system to perpetually signal pain.
Right.
So if inserting a needle into a single specific pelvic muscle can effectively reboot the autonomic nervous system's fight-or-flight loop in that region, could we eventually map and use similar localized muscular interventions to treat broader, unexplained systemic nervous system and chronic pain disorders throughout the rest of the body?
Oh, wow.
Could we essentially treat complex chronic pain by bypassing the brain entirely and just treating the hidden alarms scattered throughout the body?
Like repairing the broken security system not by trying to reprogram the main computer, but by fixing the single faulty sensor on the curtain that started the entire cascade.
Exactly that.
It's a fascinating concept to mull over. We want to warmly thank you for joining us at the table today for this deep dive. Keep questioning the consensus, keep learning about the hidden mechanics of your own body, and above all, stay curious.